بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. طلابنا الأعزاء، محاضرة اليوم عن الشولدر ديستوشيا. بداية shoulder dystocia. The objectives of this lecture by the end of this lecture, the student should be able to define shoulder dystocia, list the risk factors for shoulder dystocia, describe the possible maternal and fetal complications of such a condition, recognize the prediction and prevention of shoulder dystocia, and implement the steps of shoulder dystocia drill on the mannequin. This is an important and life-threatening situation which should be managed properly. Here in normal delivery, after the delivery of the head, with gentle traction, there will be delivery of the anterior shoulder because the head is the largest diameter in the fetus. So the rest of the body will be delivered easily with gentle traction after delivery of the fetal head. This is the normal delivery. Whereas in shoulder dystocia, after delivery of the head, you will need to exert excess traction on the fetal head because the anterior shoulder is impacted behind the pubic bone. So when the fetal shoulders cannot be delivered with gentle traction, you should not exert excessive force because this will cause trauma to the fetus. After the fetal head, dystocia, it means difficult, tocia, delivery. So this is difficult delivery of the shoulders. Incidence varies from 0.2 to 1.2%. Risk factors: if the baby is large, if the mother is small, maternal obesity will cause excess fat deposition and result in shoulder dystocia. Diabetes mellitus because of the deposition of fat on the fetal shoulders, and the head will be normal. So after delivery of the head, the shoulders cannot be delivered. Post-maturity due to ossification of the bones and big baby. Previous shoulder dystocia is another risk factor. Prolonged first and second stage of labor because there is a problem. So we can face shoulder dystocia. And assisted vaginal delivery. مريضة delivered by forceps or ventouse. نتحضر للشولدر dystocia because this may be a complication that happens after these assisted deliveries. Complications of shoulder dystocia: fetal complication, hypoxia and cerebral damage because of the occlusion of the fetal vessels in the neck. البيبي النك مالته محصورة, so there will be occlusion of the blood vessels with the resultant fetal hypoxia. Usually occurs after 5 minutes in normal babies, but if the baby is already hypoxic, for example, fetal growth restriction, this may occur earlier, 2 to 3 minutes. Another complication is nerve and brachial plexus damage, Erb's palsy, because of the inappropriate traction of the fetal head. يعني النيرس تجر الهيد بقوة لتجاوز هذه المشكلة، وهاي نهايته إنه يسوي لنا injury للنيرف, and this may end with a serious problem which is Erb's palsy that could be reversible, or if the nerves are detached completely, it will be irreversible. Fetal death: if the condition lasts more than 5 minutes, the hypoxia and brain damage, and then there will be fetal death. So appropriate management should be taken with an appropriate time. Maternal complications: postpartum hemorrhage usually result from uterine atony because of a prolonged labor. but because of the maneuvers and manipulation, there may be vaginal and cervical lacerations, and this is the main maternal risk from shoulder dystocia. Trauma to the genital tract or uterine rupture, and again, this will cause postpartum hemorrhage. Puerperal infection due to manipulation, there will be a frequent examination, there will be an ascending infection. So there will be puerperal infection. The diagnosis of shoulder dystocia: the head recoils against the perineum. This is the turtle sign. You see, when the head is delivered, it will be retracted against the perineum, just like something pulling it from up. This is the turtle sign, مثل رأس السلحفاة. The second sign is failure of restitution. With the delivery of the head, after it is delivered, there will be rotation through 1/8 of the circle to restore the relation with the shoulder. مثل ما نعرف الهيد افتار سوى internal rotation 1/8 على مود يطلع by extension. بعدين حيصير restitution through 1/8 and then there will be external rotation because the shoulder now is delivered. Failure of restitution indicates shoulder dystocia. The aim is safe delivery before fetal asphyxia and cortical damage. Prophylactic cesarean. It is not recommended to do cesarean section for all women to prevent this complication, which occurs in 0.2 to 1.2%. So, if the estimated fetal weight more than 5 kg in women without diabetes, here we may do cesarean section for the patient to prevent such a serious complication because it occurs more with big babies. And if the estimated fetal weight more than 4.5 kg in women with diabetes, because in diabetes there will be deposition of the fat in the shoulders. Okay, so 4.5 kg, if we estimate the fetal weight and we find it in such a weight, we can do cesarean section to prevent this problem. To manage shoulder dystocia, remember the alarm. A, ask for help. L, lift the buttocks and the leg, the microburst maneuver. A, anterior disimpaction of the shoulder. R, rotation of the posterior shoulder. And M is the manual removal of the posterior arm. I will explain each one of these. A, ask for help. Senior obstetrician, anesthesiologist, and pediatrician should be present because there may be neonatal problems. Prepare blood because there may be postpartum hemorrhage or surgery. Avoid, you should never do a fundal pressure. يعني ما يصير أحط ضغط على اليوتراين fundus على مود يطلع البيبي. Okay, because the shoulder is impacted behind the pubic bone. This maneuver will cause a trauma and not a benefit. Turning the patient into lateral position. احنا دائما بالobstetric ننصح نحط lateral position. Here it will be of no benefit. And avoid inappropriate traction of the fetal head. Put in mind that excessive force will cause damage to the fetal tissues. L, lifting the legs and the buttocks. This is the Mick Robert maneuvers. Hyperflexion and abduction of the thigh with flexion of the knees, usually by 2 assistants, and with this position, an assistant will pull on the fetal head. This is a teamwork, shoulder dystocia, teamwork, and we need many personnel to help us. This will change the dimension of the pelvis and the orientation of the pelvis. You see here with the flexion, this dimension will be changed. So this may help to disimpact the fetal clavicle from this pubic bone. 70% of cases were resolved with this maneuver alone. Here we see the changes in the shape of the pelvis with microburst position. A, anterior disimpaction by suprapubic pressure. We try to apply a suprapubic pressure from above on the anterior shoulder, on the posterior aspect of this anterior shoulder, we try to adduct the shoulders so the diameter will be less, and this with an assistant pulling gently here, the baby can be delivered. This is anterior disimpaction or suprapubic pressure. Like that, and assistant pull. These two maneuvers more than 90% of cases will resolve. 90% من الحالات مع هذه two maneuvers will be resolved and the baby will be delivered. If the baby not delivered, now I will do episiotomy to facilitate the internal maneuvers. Internal maneuvers, anterior disimpaction Robin maneuver. Here I introduce finger vaginally into the anterior shoulder and I press on the posterior aspect to disimpact this shoulder from the pubic bone. Okay, this is Robin maneuver. With gentle traction, the baby can deliver. If this not working, I will shift into the posterior shoulder rotation, the wood screw maneuver, just like the screw of the wood. Okay, يعني for the baby, put in mind you should keep time for each maneuver not more than 30 seconds. كل 30 ثانية أحول على المانوفر الثانية لأن هذه المانوفر ما تفيدني. Here I will apply pressure or I push the posterior shoulder to disimpact it, and then the anterior shoulder will be disimpacted. This is wood screw. Manual removal of the posterior arm. I can introduce hand into the posterior arm and I grasp the elbow, try to deliver the baby by sweeping the hand on the chest. Avoid pulling on the hand or on the humerus. This will cause fractures. Okay. After delivering of the posterior shoulder, the baby will be delivered easily. These maneuvers should be mentioned in orders. يعني نفس التسلسل اللي دا ذكره لازم نتبعه أثناء المانجمنت of this problem. If all the above measures failed, I can rotate the patient into all four maneuvers. You see here, this with the aid of the gravity, بفعل الجاذبية, the baby may be delivered. Apply downward traction to disimpact the posterior shoulder. More dramatic techniques, this will cause trauma, such as a fracture of a clavicle, symphysiotomy, replacement of the head, and delivery by cesarean Zavinelli. These are traumatic and rarely necessary. Thank you so much.